Dr. Manjak. Okay. Wow, something happened there. There we go. So these are my disclosures. I'm going to be talking about the evolving landscape of EGFR mutated lung cancer. I'm going to give a little brief historical overview, go through that quite quickly, and then talk about osimertinib. This is the product of AstraZeneca, who are sponsoring this talk, just as a disclosure. So the discoverer of EGFR was a Dr. Stanley Cohen. He seemed to realize there was something in the saliva of mice that seemed to affect the growth of epithelial tissues, and this led to the discovery of EGF and then its receptor EGFR. What that does is that it's a signaling protein on the surface of particularly epithelial cells, but others as well, that links the outside of the cell to the inside of the cell through multiple canonical signaling pathways, such as the MAP kinase pathway, PI3K, AKT, JNK pathways, etc. And the signaling is mediated through homodimerization and heterodimerization of what is in fact a family of receptors, of which EGFR is just the one. It's also known as HER1. There's also HER2, HER3, and HER4, and you can homodimerize or heterodimerize. And there's a whole bunch of ligands as well. And without going into the details of this, fortunately, what you can see is that you've got a really sophisticated signaling system that can be fine-tuned to adjust to whatever circumstances are required physiologically. And what happens when the signaling is activated is that you get cell survival, cell growth, blood vessel growing in. And this is fine as long as there's a wound that needs to be healed, and then it can be switched off. But in the case of a cancer, if it is rammed into the on position, you will really get a neoplasm, in fact, a malignant neoplasm with cells that are primed to grow, to proliferate, to attract blood vessels, and to survive and to be difficult to kill. This was realized, it was realized quite a long time ago, probably in the 1980s, in fact, that this was a system that was functioning to drive cancer growth. And so drugs were designed basically to block the ATP binding site or near there in the submembrane part of the receptor, particularly gefitinib and later on erlotinib. And these were drugs that were non-specific and interfered with normal receptor as well as the receptor in cancer cells, and as a result caused skin rash, diarrhea, and occasionally interstitial lung disease. And we didn't know at the time how to select patients for this, and so they were just often just tried empirically and approved in several countries, including Canada. This is one of my patients on the left who had chemotherapy. He was a young guy in his early 40s. He, for no good reason, was a never smoker. He developed, there's multiple pulmonary nodules. He had a pathologic fracture of his femur. He had some chemotherapy, several cycles of different types of chemotherapy, which really didn't work very well. And he was sent off to palliative care, really to die, actually. And then about 2 months later, he walked back into my clinic, and I thought that either he was on drugs or I was on drugs. I thought it was a hallucination, but this was his CT scan. And in fact, he'd had a very substantial resolution of these multiple pulmonary nodules. So it turns out my GP oncologist had managed to get hold of some gefitinib and actually gave it to him on his way to the palliative care hospital. And so he survived for a long time on this drug. We didn't know at the time, but it was in fact about a year later that the discovery of the EGFR mutation was responsible for these rare but outstanding responses. And this was discovered and published in Science by two groups. Since then, we've learned that there's multiple different ways that this receptor system can drive cancer. It's not usually ligand overexpression. It's often receptor overexpression, unmutated. Sometimes the receptor may be truncated and in an activated, constitutively active formulation, such as in glioma, for example, or a mutation in or around the ATP binding pocket, which holds the receptor in an active state. It soon became clear that there were mutations were pretty much confined to exon 19, where there was a deletion around the 750 region, and also a point mutation in exon 21. But there were some atypical and occasional mutations in exon 18 and also in exon 21 that seemed to drive oncogenesis as well. Now, this is just a kind of a schematic of the extrahepatic domain binding the ligand. There's the transmembrane, which anchors it in the membrane. There is the P loop, which contains the ATP binding site, and that's where most of these activating mutations occur. Now, it was known that the mutations were not entirely confined, but most often seen in a particular phenotype of patient, that is a light ex-smoker or a never smoker, often female, often Asian. And so this mutation appeared to be very common in East Asia. And as a result, the IPOS study was done pan-Asia, comparing chemotherapy to gefitinib. Initially, when the study was started, they didn't really know about the mutation, so they accrued just based on the phenotype. And then ultimately, when partway through, it was discovered that the mutation was present, and these patients were then analyzed retrospectively based on the mutational status. And what you can see here, that is in the solid green line, this is gefitinib in the EGFR mutated population. In the dotted green line is gefitinib, in the EGFR negative, is clearly inactive. In the solid line is carboplatin paclitaxel in the EGFR mutation. So if you got a mutation, gefitinib was definitely better progression-free survival-wise than chemotherapy. If you were mutation negative or positive, the carboplatin paclitaxel was very, very similar. So basically, you got this really rather striking picture emerging, which has been confirmed multiple times, was confirmed very rapidly thereafter with erlotinib, showing the same kind of thing with the benefit of the erlotinib in the EGFR mutated population. But by the way, no survival benefit in this trial, because the placebo arm, or the chemotherapy arm, was able to cross over to erlotinib, and that basically eliminated the survival advantage. But what we see from Japan here is the yellow line showing the survival of patients with the EGFR mutation, which was done on banked tumor specimens later on, prior to the introduction of gefitinib, and then their survival after the introduction of gefitinib. And you can see there's a striking difference. In fact, it more than doubles from 13.5 to 27.2 months. Whereas over that same time period, there was no difference in the chemotherapy in the EGFR negative patients. So it wasn't due to a change in the standard of care. So there's no doubt that the introduction of this drug had a major impact on public health, particularly in countries with a very high incidence of this disease. Now, we have learned from multiple studies that the deletion 19 is somewhat more common than the L858R, but both of them are far more common than atypical mutations. The other thing we discovered pretty soon was that there was a rough association between histotypes of adenocarcinoma. So, for example, if you see this word papillary, there was a much greater chance that there would be an EGFR mutation in this kind of seaweed configuration, and including in the micropapillary, which is actually a highly aggressive tumor. You see this kind of budding is much more florid in the micropapillary compared to the papillary, and that is also strongly associated with EGFR mutations. Whereas if you have just a plain acino, it may be around 10%. If you had a solid, poorly differentiated adenocarcinoma with mucin, it was very rarely associated with an EGFR mutation. And there's similar associations with ALK and so on and so forth. So now, of course, we rely on the fact that we get the mutational status on all non-squamous carcinomas. But previously, there had to be this kind of, what is the probability, and, is it, isn't it kind of thing. Unfortunately, as you see here, there's a good response going from the left to the middle here. But unfortunately, good things don't last forever. And so these tumors tended to come back after a period of control, which was around about 10 to 12 months. And this was likely to be due, at least initially, to two mechanisms. One was the additional mutation in exon 20 of the T790M, which is the methionine, replacing the threonine. And that makes it sterically impossible for first-generation TKIs to get in there, or a MET amplification by bypass were the two common ones initially realized. And so this led to the design of afatinib, which is a drug that binds covalently to the entire family of her receptors, human epidermal receptors. There was great hope that this would be the solution to the T790M. You can see the covalent bond there, an irreversible binder to the whole family. This led to a number of studies So here's afatinib versus chemotherapy, showing progression-free survival in the common mutations, quite a strong benefit, possibly at 13.6 months, a bit longer than gefitinib or erlotinib. You can see that, again, the major benefit in deletion 19 compared to 858, which is a theme, and then overall survival in the deletion 19. But one of the interesting things here is that if you look at overall survival, you see in the deletion 19 that is unquestionably it was better with afatinib. But interestingly, in the 858, although there was a PFS advantage, there wasn't a survival advantage. And so that's a little kind of interesting side story here that I won't really go down, but the 858 doesn't do quite as well as the deletion 19. And unfortunately, with afatinib, it did turn out to be considerably toxic with rash, diarrhea, and paronychia at the dose level, leading to frequent dose reductions. And so really the bottom line is that this drug really had a limited benefit as well, maybe a little bit longer than the first generation, but you couldn't get the dose high enough to deal basically with the T790M mutation in particular. We do see that with afatinib that the progression-free survival tended to be a bit longer than with gefitinib, for example, but unfortunately did not prove to be the answer. This is afatinib versus gefitinib. This is a direct comparison. And really what you see, a PFS by independent review, see a very, very modest improvement. Really nothing at the 50%, but a hazard ratio of 0.73. Objective response a bit more, but it is more toxic, with AEs leading to dose reduction of 42% compared to 2% with gefitinib. By the way, gefitinib, not entirely innocent of side effects. You do get a bit of transaminitis and interstitial lung disease, but certainly more subjective toxicity on the afatinib. And if so, afatinib really, this is the overall survival, really not showing a statistically significant benefit, unfortunately. Deletion 19858R. So really at this point, we were left with this conundrum of, we had identified a major resistance mechanism, the T790M, that applied to these patients with first generation TKIs. Unfortunately, afatinib was not the answer. It was only slightly better, but considerably more toxic. And so people had to think differently about it. And so this led to the advent of this drug, osimertinib, really to deal with this phenomenon of resistance, primarily in the first instance. And this is the incidence of T790 mutation-associated drug resistance in patients on first and even second generation TKIs. There are certainly other means of drug resistance, including transformation to small cell or even squamous cell, HER2 amplification. And there are some that we don't even know what the mechanism of resistance is. But very frequently it's related to changes in the EGFR target itself, especially the T790M mutation. And there you can see in a schematic here, this is the erlotinib fitting in quite nicely to the native cleft. And this is the addition of the substitution of methionine for threonine at the 790 codon, causing the steric hindrance here and pushing the erlotinib out. Also, MET amplification through a bypass pathway was something that occurred somewhat less frequently, and transformation to small cell. And there are other mechanisms like axil amplification and so on. One of the interesting things that autopsy studies have enabled us to show is that these metastases are like separate island universes where you sometimes get different mechanisms of drug resistance. So, for example, two of them here have transformed to small cell, albeit with a different mutation. But the non-small cell here actually has a different mechanism entirely in the liver. And so remains its adenocarcinoma morphology and is associated with a T790. So one of the problems about getting a blood test to determine the resistance mechanism is that actually there may be multiple different resistance mechanisms, and the blood test may not be a complete reflection of all of the metastatic lesions. Now, of course, it's a bit of a complicated landscape as to the resistance mechanisms that may be possible, but the T790 mutation was common. But there's certainly no doubt that we seem to understand that there are non-EGFR related mechanisms, FGFR, MET amplification, HER2 amplification occasionally, and other mutations apart from T790 within the EGFR itself. So therefore, but focusing on the T790M, on the left here, you see gefitinib, you see the normal T790, he has the methionine pushing it out. But this is osimertinib, a kind of stick representation here. Here's the T790, which is nowhere near the osimertinib, originally called AZD9291. So you can see this fits into the cleft, inhibits the ATP binding site, but is not bothered by the T790. It's not specific for the T790M, but it just tolerates the T790M. So on the top here, we get the schematic whereby it doesn't really bind that strongly to the wild type. I think it's a little bit misleading because it implies it doesn't bind at all, and that's not true. But it doesn't bind as strongly as gefitinib underneath. It's okay with the EGFR mutation. It's okay whether there's a T790 there or not, but it does not require the T790 to work. Whereas the gefitinib or erlotinib, they bind the native EGFR, but they don't bind when there's a T790 mutation. So the idea is that it would be that osimertinib would work with it, whether or not the T790 was there or not, but it would bind less to the normal and be less associated with these drug-limiting toxicities. So in terms of the trials and approvals, this initially came in with I just focus on the randomized trials here. The AURA3 study was a randomized study of osimertinib versus platinum pemetrexed in patients who had a T790M mutation as the reason for resistance after first generation TKI. And you see here a large benefit, 10.1 versus 4.4 median with a hazard ratio of 0.3, an unusually large hazard ratio. And all of these subgroups with or without CNS metastases, Asians, non-Asians, males, females, age, or the particular type of mutation, it didn't matter. All of these subgroups benefited. And the toxicity compared to platinum pemetrexed was substantially less. It's not zero, but it is certainly substantially less than chemotherapy. And the CNS responses were fairly dramatic. One of the other attributes of this drug is that it gets into the central nervous system in concentrations that are adequate to suppress the disease and shrink it without causing CNS side effects. So this is unusual, and it's a very striking attribute of osimertinib. And you can see the response rate in the CNS was 70%. Versus only 30% for chemotherapy. And it was durable, as you can see here on the left. And this is the overall PFS in the patients with CNS metastases. It worked whether there was CNS metastases there or not, compared to chemotherapy. Now, the FLORA study was the shift of this drug into the first line compared to chemotherapy, compared to the standard of care, which up to that point was either gefitinib or erlotinib. So this was a double-blind study, a gold standard design in patients with the common mutations, compared the standard dose of osimertinib 80 versus either gefitinib or erlotinib, and that is the choice of the physician. And what we see is that there is a response, which is not dramatically different between top and bottom if you look at the waterfall plots, but you do see that the response, that the threshold for response rate shifts is somewhat left shifted in the osimertinib, and there's a few more people with complete responses. So the response, the debulking with osimertinib is a bit more, but it's not strikingly more. But what is striking was the progression-free benefit of PFS survival compared to erlotinib or gefitinib. And this, again, applied to all groups. And I want to stress it was both the exon 19 and the exon 21 patient subgroups. The PFS here was 19 months versus 10 months. And this led to osimertinib being approved and available in second line with the T790 mutation, which is where we first started to use it. And if we look here at the, now in first line, having shifted from second line to first line, if we look at the survival, this is the updated survival final analysis presented in 2019, we see a survival of 38.6 months compared to the usual sort of 24, 25 with gefitinib. Now there was some crossover, but the comparator was 32 months. And this really was the face that launched 1,000 scripts as opposed to 1,000 ships. If you're familiar with Christopher Marlowe, you'll excuse that. But this then led to the very substantial use of osimertinib in first line around the world. We see a big benefit of 42 versus 31 in the deletion 19, a more modest benefit in the 858, but I will want to stress that There was CNS protection in the 858. There was progression-free survival in the 858. So we had migrated to using osimertinib in first line in both deletion 19 and 858. This is the probability of PFS with patients with CNS metastases at baseline with an excellent hazard ratio of 0.48. This is the CNS response, including some patients with complete response. And there is now, I think, very easy to see there's more substantial debulking of tumor in these patients who were allowed in with stable CNS metastases. In terms of the side effects, there's a bit more leading to discontinuation, 18% versus 13% on osimertinib. So I think it's wrong to say that osimertinib is non-toxic, and that's not right to say that, but it is less toxic than gefitinib or erlotinib or a dealer's choice kind of thing. So if you want to know the specifics, there's less in the way of skin rash, and there's less in the way of transaminases, but there's still a bit of paronychia and stomatitis. And I have occasionally had a dose reduce patients from 80 milligrams down to 40 milligrams. There is a 40 milligram tablet available, and I find that the toxicity responds pretty well to a dose reduction. So this, of course, was part of a major expansion program, which includes the adjuvant study, ADORA, which I'll talk about next, but also LAURA, which is the stage 3 kind of equivalent of Pacific 9, but with osimertinib rather than with durvalumab. Now, what is it about, what's unsatisfactory about the adjuvant systemic therapy of resectable non-small cell lung cancer? So a lot of the time, more than half the time, in fact, patients don't even receive chemotherapy because the surgeons, tell them they've got it all, quote unquote, or, they're too beat up after surgery, or they just can't face the idea, or they have a surgical complication that leads to a delay. Multiple reasons why they legitimately may not want to have chemotherapy. And even if they do have chemotherapy, there is a significant rate of recurrence, even in stage 1B, of nearly 50%, in stage 2, 60%, and stage 3, 76% of people recur. And most of these recurrences are, in fact, outside the chest in unpleasant sites such as the brain, bone, and liver. And there's the issue of an alternative regime now, an alternative regimen called the Checkmate 816 study, carboplatin, paclitaxel, and nivolumab, which is highly efficacious, very interesting, and very exciting, but did not include patients with EGFR for obvious reasons, that they don't respond well to immunotherapy because they are not particularly mutated. However, in order to put people onto this study or into this regimen, you have to know what the EGFR and ALK status are. So you need to test people who are resected, and you can either do it according to the NCCN on the original biopsy through EBUS, or you can do it based on the resection specimen. It's best to do it as quickly as possible. And so this study randomized patients who'd been resected 1B to 3A, and they may have had chemotherapy, that was again dealer's choice, but after that to osimertinib at 80 milligrams to placebo control. And this was a study done across the world, both in Asia and in the West, in good performance status patients who had to have either exon 19 or exon 21, and they may or may not have had adjuvant chemotherapy. So this was published first in the New England Journal in October 2020 and was updated at the recent Paris ESMO in 2022, and I'll give you the updated results. Here is the disease-free survival in stage 1B, 2, and 3A, in fact, the entire population. And you can see that there is a huge benefit with a hazard ratio of 0.27, very substantial protection for the 3 years. So this is 3 years of osimertinib. It's a long time, okay, but it does work, and it works very well. What you do see, however, is that once the osimertinib stops, you start to see relapse in these patients, which leads to the very obvious question as to whether it should be continued beyond 3 years or not. There is a study underway to look at that. I'll just mention that. If you look individually at stage 1B, stage 2, and stage 3A, you can certainly drive a small aeroplane through that one. You can drive a moderately sized aircraft through stage 2, and you can drive a wide body jet through stage 3A. The hazard ratio improves with increasing stage, but of course the the quid pro quo is that you have a lower rate of relapse when patients stop at 36, when you can see the relapse is not so great in stage 1B. It's a bit more in stage 2, and it's quite sharp in stage 3A once you stop this treatment. So this then raises the question as to not only should you go beyond 3 years, but in whom should you go beyond 3 years? In any event, it's all good news for the first 3 years, and maybe beyond that, all of these groups benefit. And again, the exon 19 benefiting a bit more than exon 21, but this is still a huge benefit in disease-free survival, even in the exon 21, with a very acceptable hazard ratio of 0.45 and a spectacular one in the deletion 19. What about CNS recurrence? The CNS, it's extremely protective in the first 3 years. But when you stop it, you start to see a bit of relapse within the CNS. And again, people's brains are important most of the time. And so again, this is another argument that it might need to be continued. And does it need to be continued in everybody? Maybe not. And this is possibly where circulating tumor DNA is going to help us make a decision. Sites of recurrence in the patients on osimertinib, very little recurrence, such as there was mostly intrathoracic. For patients on placebo, there was much more recurrence, and most of it was, in fact, outside of the chest. Here is the CNS protection and CNS recurrence, and the blue dotted line out to 36 months really is the excellent CNS protection for patients on the osimertinib. And you see the yellow dotted line is the CNS recurrence starting to quite quickly in people on placebo. And the dashed lines is the extra CNS recurrence. It was consistent, by the way, regardless of prior adjuvant chemotherapy. Now, who got prior adjuvant chemotherapy? It was much more likely to be the stage 2s and the stage 3s than the stage 1Bs. This is not a study of comparing the benefits or lack of benefit of adjuvant chemo. It's just to say that whether you got adjuvant chemotherapy or not, osimertinib provided additional benefit. Okay, we've talked, this is the overall survival, which is currently immature, but is trending a little bit in favor with a hazard ratio of 0.4, but it's really too early to say whether there's a statistically significant survival benefit. Now, we're on this drug 3 years, so it better be relatively non-toxic. There is mainly, if there is toxicity, which there maybe isn't in the majority of patients, but if there is, it's mainly a bit of diarrhea, bit of paronychia. It's usually grade 1, grade 2. It is not nothing. It needs to be managed because even grade 2 side effects can impair quality of life, and people are on this for a long time. These toxicities do respond to dose reduction. Very few of them are significant grade 3, 4. In the placebo, of course, there are toxicities for what that's worth from nothing. So I guess what you have to do is subtract the yellow from the blue to find out what is the additive toxicity in reality, and it's not that bad. But you might need to do an ECG, be cognizant that this drug can prolong the QTc interval. It's important to test these patients. The NCCN has acknowledged that osimertinib is a drug of choice in EGFR mutated patients, either instead of or in addition to adjuvant chemotherapy, and therefore you require a test either on the original biopsy or on the definitive resection. And it is far better to be in a situation where this can be turned around quickly, because you may be thinking about putting people on some other kind of treatment. Now, the future. This is a little bit more of a complex, detailed discussion. And I'll just go through some of the studies that are ongoing. So this is a study in the, as I said to you, the ADORA was in stage 1B, 2, and 3A, resected. There are smaller tumors, stage 1A, 2, 1A, 3, sub 3 centimeters, and those were not included. But this study is ongoing in these much smaller tumors, OSI versus placebo. I'll just say that's going to take, obviously, a longer time to accrue. The target study is in patients who are 1B to 3, stage 2 to 3B, where the incidence of recurrence is high beyond the 3 years, and this is carrying it on to 5 years. Now, this is not a comparative study. This is a single-arm study with 180 patients. So this might change treatment, but it's going to take a bit of time to get the result, obviously. NeoAdora is a neoadjuvant study, osimertinib plus platinum chemo versus platinum-based chemo versus osimertinib alone. Now, this has been criticized by eminent thought leaders within Canada as not containing a standard of care, which is nothing. But I'll just mention that NeoAdora is ongoing and will ultimately accrue 328 patients. LAURA, I mentioned, is the sort of EGFR mutated equivalent of the Pacific study. Stage 3, locally advanced, unresectable, definitive chemoradiation. You then find out it's an EGFR mutated situation. Maybe there's not such a good rationale to put it on patients on durvalumab. Maybe the preference here would be an osimertinib type approach, but this needs to be established in the study, which is, I think, well on the way to reporting. So hopefully we'll get that result soon. FLORA-2, I think, is upcoming quite soon. This is an interesting study of patients with advanced systemic treatment naive, in other words, first-line treatment of osimertinib, also with and without chemo. There was a safety run-in, but here's the randomization 1-to-1, osimertinib versus osi plus chemo. If you get chemo, it's pemetrexed, platinum doublets, of course, followed by osi and pemetrexed maintenance, with PFS being the primary endpoint. This study, we feel, is going to report quite soon. So watch this space. This could radically transform what we do in the first line. But that being said, even if it were to be positive, there are people who don't want chemo. And so osimertinib by itself still remains a pretty decent choice. So again, it's going to need to be individualized. Why should people have chemo in addition in first line? And I'll show you a couple of studies, but it might depend on additional risk factors such as the presence or absence of P53 or other nasty genes. But there are interesting studies that justify this. In Japan, for example, this is the NEJ009 study, which looked at gefitinib with or without chemotherapy. And this chemotherapy showed a marked benefit in the progression-free survival with a hazard ratio under 0.5, as you can see there. And this is the overall survival, which now these are, of course, Asian patients who do tend to survive longer. This hit more than 50 months in the chemo plus gefitinib arm, a really rather interesting result. This study was, a similar study was also done with carboplatin and pemetrexed in India, and you can see both a progression-free and an overall survival benefit from the same kind of study design. Now, there are other ways, of course, to deal with resistance, and if the disease is driven by MET, there are MET small molecules that can be added to osimertinib versus osimertinib alone. This is in first-line treatment. So what about osimertinib resistance? Okay, so here is what I think is a reasonable algorithm. Patients with common mutations, first-line osimertinib, it's funded, it's available. Second-line platinum pemetrexed. If you're a believer in bevacizumab, you can add it. I tend to do it if I can get it, but many people don't, at least in Canada. And then you're kind of stuck, docetaxel, third line, ramucirumab, if you believe that, it's not funded. And then you're kind of out of luck. Now, here's a study just to look at bevacizumab with osimertinib. I'll just mention it very briefly. It hasn't gained a lot of traction. This was done in Japan, common mutations. And I will show just some interesting facts here. They did show a benefit in the ever smokers, interestingly. Why? I don't have the faintest idea. In the never smokers, there was really not a benefit. In fact, a mild detriment, if anything, hazard ratio against it. But a 0.48 hazard ratio, now this is small numbers, about 30 patients in each arm. What does it mean? Who knows what small freak, studies or what, does it mean anything? I don't know. It also showed a benefit in deletion 19, hazard ratio 0.62, but not in exon 21. I have occasionally used it in patients with brain metastases. I will say it is perfectly safe. Is it the right thing to do? We don't have enough data to say it is or it isn't. But I'll just make the point that it is now fairly well established that if you have a P53 or even an RB1 and P53 mutation in association with your EGFR mutation, you do worse on standard first-line treatment, be that osimertinib or the first generation or second gen. And these curves quite clearly show that from the Journal of Thoracic Oncology. So I'll just make that point. Now, what are the resistance mechanisms that occur on first and second line osimertinib? The answer is there are a lot. It's not like the first generation where it is purely a T790, and that's that. And then you've got, like, at least in most of them, and then you've got a single solution to it. It is a whole bunch here. The common ones might be, secondary EGFR mutation, C797, said to be common, but, it's a big deal. What is it? It's a small minority of patients. HER2 amplification, 2%. MET amplification, 15%. That's the biggest single one that we know about. Often we don't have the faintest idea what it's due to. And so as a result, here's a study of chemotherapy with osimertinib versus placebo chemotherapy in patients who experienced progression. So this is a continuation study where you have osimertinib, you fail on it, and you then randomize to chemotherapy alone versus chemo plus osimertinib. So chemo, of course, is agnostic to these various mutations, probably, and so is a very reasonable strategy. In future, we may have antibody drug conjugates in this space. Now, ORCHARD is a study that attempts to match drug-resistant patients who are resistant to osimertinib to a particular target. So if there's a 797, there's a belief system that gefitinib or erlotinib may be effective to add to osimertinib. If it's MET, you go with savolitinib. If it's ALK, you go with alectinib. If it's RET, you go, et cetera, et cetera. And if it's transformation to small cell, you go with chemotherapy. And if it's not matched, you might just go with these, as you can see here. Savannah is osimertinib plus an anti-MET drug versus savolitinib itself. Saffron is a similar kind of thing, osi plus savolitinib versus platinum-based chemotherapy in MET-driven cancer. Targeting MET with small molecules is effective. You can see osi and savolitinib, or savolitinib or gefitinib and capmatinib. They work for a while. But the new exciting kid on the block is amivantamab, which is an interesting bispecific antibody against both MET and against EGFR. So it's a bispecific antibody. Once it's stuck on, it operates by something called trogocytosis, which is when macrophages kind of gnaw away at the tumor cell, that kind of eat it to death, or natural killer cells can kill it as well. So it has a rather complex mechanism of action. Whatever it is, it works. You can see AMI by itself, or AMI plus lazertinib, which is another third generation CNS penetrant TKI, post-OSI, 27% up to 36%. So it's active in people with osimertinib resistance. There's a complicated clinical trial program associated with this. Here is an interesting study called Mariposa, which we were all waiting for. They thought it was going to read out recently, but unfortunately, or not fortunately or unfortunately, there wasn't enough data yet. So this readout has been deferred a bit. So this is in patients first line amivantamab and lazertinib versus osimertinib. That is the main comparison that we're interested in. And there's a third on lazertinib alone. Chrysalis 2 was a previous study which did have a cohort post osimertinib. And by the way, amivantamab is approved in exon 20, which I'm not going to talk about here. But this is in the prior osimertinib exposed. You can see that there's considerable activity in osimertinib resistance here, which is fairly durable. And so there is some now first-line data in a small study. This is the first-line data showing, in fact, the objective response rate was 100% in systemic treatment naive. These are people who have not been exposed to osimertinib, amivantamab, and lazertinib. You can see a really impressive response rate. It is fairly durable. And this is the duration of response, which of course was in everybody. And by cycle 3, no patients had detectable ctDNA as a biomarker. And the safety profile is a bit of a concern with this drug, particularly infusion reactions around the first cycle. So it's not a drug that's innocent of side effects, by the way. So that's the downside of this drug. Of course, we're very interested to know the result of this Mariposa study. Again, watch the space, but of course, the standard of care might have shifted to chemo plus osimertinib with FLAURA2. So this is a very dynamic situation. There are other drugs that are active. Here is an antibody drug conjugate, patritumab deruxtecan, very active in EGFR mutated non-small cell lung cancer. Again, where's that going to fit? TROP2, again, this is not against the EGFR, but is against trophoblast cell surface antigen 2, is active in this disease. You can even consider re-challenge with the TKI. And our study, Ocelot, which thank you for the mention of that, Dr. Menjak, is ongoing 10 centers across Canada, allows people to get osimertinib re-challenge after they've had second-line platinum pemetrexed, and they can enter the study at second line as well, and or at third line. Originally, it was going to be studies all the way through from first line, but because it became commercially available, we were not able to do that, but we can still enter patients in second and third line, and I would encourage you to enter people on this study. We are actively accruing. The other part of this, which I haven't had time and won't have time to talk about in this talk, is that there are atypical mutations, somewhere around 15% of EGFR activating mutations, non-exon 20, or atypical exon 18, exon 21, etc. They are oncogenic drivers. Traditionally, they've responded quite well to afatinib, but again, as I've said, it's quite toxic. They are allowed on the study in first line, and I can share with you that osimertinib in first line, so far, we have about 30 patients, is highly active in most of these types of mutations. So again, very enthusiastic about continuing to accrue both the typical mutations in second and third line, as well as the atypical mutations who can get it in first line and then all the way through. This shows the activity of afatinib, which is quite impressive in these atypical mutations. But I'm going to make the point again, this is a drug that is somewhat toxic, and it is better to have a less toxic drug such as osimertinib, which is definitely less toxic than afatinib at standard dose. So here's a possible future scenario. This is me telling the world what to do, so take it with a pinch of salt or whatever else. So I think we may see a migration to osimertinib plus platinum pemetrexed as per FLAURA2. And maybe you could throw in bevacizumab in the smokers. I'll just put that in there for fun. Second line, I believe, will be amivantamab and lazertinib. That's what I think. And when the third line, patritumab deruxtecan, and only then maybe docetaxel or even possibly re-challenge osimertinib. So this is just a little prediction thing for fun. It may turn out to be completely different. I may have to eat my words on this, but this is a possible scenario going forward. So in terms of the attributes of this drug, superior PFS and OS versus dealer's choice in first gen has led to it becoming standard of care in the first generation. It's highly active against T790M resistance in any line, not just second or third line. It has outstanding CNS penetration without CNS side effects. It has somewhat less toxicity than other available TKIs due to its relative selectivity for the mutation over the wild type, but that is not absolute. It can be safely combined with VEGF inhibitors and or chemotherapy, but do not combine it with immune checkpoint inhibitors because you get an unacceptably high rate of pneumonitis. And bear in mind that if patients have been on an immune therapy because you're anxious to do it before the EGFR result arrives, you put them on Pembro or something, that takes a while to wash out. So don't give the osimertinib either on the Pembro or any immune checkpoint inhibitor or Durva, and wait for it to wash out, because you give it immediately afterwards, there's also the risk of pneumonitis because the antibody hangs around for a while. It's probably safe to combine with radiotherapy or in close proximity to radiotherapy. And there is a very large, interesting international clinical trial program ongoing, but also a number of competitor and supplementary agents. And with that, I'm on 45 minutes and certainly open for questions. Thank you.
Fantastic talk. Thank you so much, Dr. Vincent. While people start kind of putting their thoughts and their questions together, I might ask a quick question just to get it going. We heard some amazing improvements in terms of the options and the upcoming studies. Where are things at in terms of, ctDNA testing, let's say in terms of monitoring response to therapy, either metastatic or in these patients who, are on the 3 years of adjuvant therapy. Is there any data or any rule that looks like it's coming for ctDNA testing to see some of these emergent, resistance mechanisms?
Yeah, so I'm not familiar with hardcore data. We are, as part of the Ocelot study, actually collecting ctDNA. And that would be, of course, we can't do it in first line, but we're doing it at the end of first line. And in addition to tissue biopsy as well, if people would agree to it, and then ongoing through chemo and through third line. So we'll have some data eventually. There's certainly data from non-small cell lung cancer as a whole that it is potentially very useful and will give you a lead time. And there are more and more sophisticated methods of measuring ctDNA, because if you get down to when it's very rare in the blood, it starts to get confused with the statistical noise. But there are more sophisticated, more sensitive methods of detecting it that are being developed, particularly out of Stanford, actually in the US. My personal belief is that it's going to be extremely useful as an early readout to know whether people are responding in the first instance. And that does require that it be quantitated, because you need to see a drop or an elevation or stable to know if it's quantitated. But I would just mention something that, you can get a fairly quick readout with CEA. So I routinely measure CEA, CA99, and CA125 in these patients with adenocarcinomas, and almost 100% of them will elevate at least one of those markers where it is quantitated. Now, our lab comes back with a quantitated, whatever it is, CEA, 15.3 or whatever. And within a week or two, you can remeasure that and you can tell if they're going to benefit or not. So even a CEA, something which costs $10 probably, or a CA99. By the way, some of them don't express CA, they express CA99, which is said to be a bad prognostic sign. It's another utility of that. So you don't necessarily have to spend a lot of money on something cutting edge, even though it's kind of nice to do it. You can spend a little bit of somebody else's money on a very crude old thing that is still quite useful very quickly. So personally, the CEA, CA9 is not going to tell you about the emergence of resistance mechanisms.
Mm-hmm.
It may tell you the emergence of resistance, because it does give you a lead as well, but it doesn't tell you the mechanism. So is it going to be MET? Is it going to be C797S, or whatever it's going to be? So ctDNA, I think, is going to be highly useful to tell us about resistance mechanisms. And of course, it's going to be whether or not there's a drug that's available specifically, or whether you just have to hit them on the head with something like patritumumab, which is just basically a hammer that will squash any kind of insect, or even radiation therapy to the lesions that seem to be behaving badly. So I didn't talk about stereotactic radiation, but it is something that is extremely useful in this setting and would allow you to keep on an EGFR TKI longer in many cases. And the NCCN has endorsed stereotactic radiation for those patients who seem to have limited disease progression, whereas most of the disease is still kind of under control. You can burn those few and then continue sometimes up to 6 months or more with your systemic treatment. So I do think it's a technology. It's not funded standardly. It's expensive. Like everything, the cost has got to come down, and the cost will come down with competition and technological progress. And I do believe we'll integrate ctDNA in the care of this, as well as multiple other situations in non-small cell lung cancer.
Thank you. Anyone else have any questions?
Yeah, I have a question. Thanks, Mark, for your talk. When I was working with you in London, I would see one EGFR patient a year, and now in my clinic in Toronto, I see a couple per clinic.
Yeah.
So this is very, very, I think, helpful for our team to know both the historical context as well as get another perspective on what the current lay of the land is. One comment and then a question. So the first comment is, I saw on Twitter earlier today that FLAURA2 is actually positive. There was a media release, and then it was amplified on Twitter. So it said both statistically significant as well as clinically meaningful. I guess the question will be, as you pointed out, with a PFS benefit, will that be sufficient to kind of swing adoption and or convince patients to accept the extra risk of chemo up front? And will it translate to a survival benefit? My question relates to radiation, and I'm pleased to see that you're adopting the mindset for oligoprogression. What are your thoughts about even earlier on? So the SINDAS study that you're familiar with was looking at sort of pre-Tagrisso TKIs. And even though there's some issues with the study, it was randomized, showing maybe a PFS and OS benefit. There is a Tagrisso specific study looking to give up to 5 sites radiotherapy up front at the very beginning, and then the Tagrisso, and that's going to read out shortly. Wonder what your thoughts are about using radiotherapy even earlier on.
Yeah, I would actually, encourage people to keep a very close eye on the space and to work closely with, thought leaders such as yourself and other radiotherapists, because I do believe that these large tumors are factories of drug resistance. They have what's called persister cells. So even if you shrink the tumor substantially with, a TKI like osimertinib, or even with chemotherapy, you are going to be left with these persister cells. Now, I'll just draw your attention to this journal, and you can probably get it through your library. There are 2 very, very interesting papers. One, here's molecular biomarkers of disease outcomes and mechanisms of acquired resistance to osimertinib. This is a very interesting article on page 463 of the April edition of the JTO. And also another very interesting paper from Toronto, Francis Shepard, Jeff Liu, Ming Tao et al. On the single cell analysis transcriptomic features of drug-tolerant persisters, which seem to show a very interesting kind of crosstalk between the cancer-associated fibroblasts, which seem to be primed to talk to each other to encourage drug resistance in these minority persister cells, which cannot be eradicated by osimertinib alone, and maybe not even by chemo. But I think radiotherapy has the ability to do it. So I strongly think that if you can, hammer down, now you can't irradiate everything, of course, and there's a real question as to what's the limit, but I do think that radiation should be part of this. Now, if you've got a 5-centimeter tumor, should you shrink that first with osimertinib and then radiate, the 2-centimeter residuum, or should you radiate the thing prior to osimertinib? I think is an empirical question that's impossible to logic your way to. I think we just have to test about the sequence and so on. But I would strongly endorse anything that debulk the tumor as much as possible, because it minimizes the opportunity for stochastic mutational drug resistance. And also, if you can find a way to hammer the stroma, it seems that not only do we have to hammer the tumor cells, but we have to hammer the stroma, because the stroma has the ability to keep the tumor cells alive. And so the question is, what is the nature of this talk between them? We know that in pancreas cancer this happens, and in other cancers like breast cancer, there's a very strong association between tumor cells and the fibroblasts that actually provide a lifeline of support to the tumor cells. And that might be due to something called leukemia inhibitory factor, which is, despite its name, part of the interleukin family that is actually providing a survival signal. AstraZeneca actually has a drug, an antibody that can block leukemia inhibitory factor. And so they were interested in that in the pancreas cancer context. But I think we're going to learn a lot in the next couple of years about how and why these drug persister cells are able to stay alive and repopulate the tumor with stochastically mutated drug-resistant cells that become untreatable. So I think this is the next academic the next intellectual barrier to understand what is going on deeply in the tumor with single-cell genomics. And I've just been to the AACR, and I can tell you these people are creating the future. They're building the future with the single-cell genomics and getting a really deep understanding of what it is that's going on inside that tumor. And that may even be reflected in the bloodstream, by the way, indirectly, that we can then add an additional layer of new generation drugs to actually solve this problem once and for all. In terms of your original question about how to persuade, can you persuade people to have chemo with the FLAURA2? I think it's just a PFS. We don't have the survival data yet on Twitter, right? So the answer is, how big is the PFS and who benefits, cui bono, as the Romans used to say. Who benefits? Is it everybody? Is it just a little bit in everybody, or is it a lot in a few people? And if it's a few people, can you identify from the forest plot who it is? Is it the exon 21s? Is it the people with P53 mutations, the co-mutational? Is it the people with bulk Is it the people with liver metastases? You know, we'll see when the details get, as I'm sure people are going to very anxiously look and try to figure out who needs chemo, because a lot of people who don't want chemo and would rather have it deferred. So this is going to be a very interesting conversation. You know, and maybe if you can radiate, you know, the big sites, maybe you don't need the chemo, right? So, yeah.
Thank you so much for that fascinating discussion. Any last question before we have to disconnect? I guess a quick question from my side then, because we touched on the immunotherapy. Obviously, there are dangers with kind of the proximity in treatment with pneumonitis. And then we saw the data from Keynote 789 with the immunotherapy and chemo not benefiting patients with EGFR. Are there any instances where you would ever offer immunotherapy to an EGFR patient, knowing what we know now?
Yeah, so, you know, I think as a last line, it's not an unreasonable thing to do, you know, because if they stop the osimertinib, if that's the last line, or they're on chemo, then they're well away from the osimertinib, gets out of your system quickly. So I think the sequence of, you know, immune checkpoint inhibitor following osimertinib is fine. And quite often the PD-L1 is strongly expressed in these people with EGFR mutations. Now, people say that that is just downstream of the EGFR mutation. It may not mean the same thing that it does in a smoker, where the tumor is trying to protect itself from the immune, you know, it acts as a shield. But there are a considerable number of people who smoke, and smoking does not immunize you against EGFR mutations. So I'd say in the Western world, there's maybe 20 to 30% of the EGFR mutations patients are current or, you know, relatively heavy ex-smokers. And if those tumors are mutated like they are in most smokers, even though there may be an EGFR driving it, I do suspect that those people might benefit somewhat from an ICI. Now, we don't have a way, you know, we don't have an assay for the tumor mutation burden, but in principle, and you can even get that from the ctDNA, for that's another use of ctDNA, you can get a kind of a crude estimate of the tumor mutation burden. So I think that there may be a smoking subset of the EGFR mutation patients who might benefit somewhat. And of course, we have the IMpower 150 study, which did in a relatively small number of people show what appeared to be a benefit of bevacizumab and atezolizumab. Now, is it the bevo that you need for that? You know, I don't know. We don't know. Roche tried to get an approval for that. You know, the regulators came back and said there are just too few patients here, go and do it again. And they haven't. So as far as I know, it's going to be, I don't know. But in the meantime, I'm prepared to give an ICI as a last line treatment, especially to a smoker.
And I was wondering that myself, if whether it's really the tumor mutational burden that should kind of drive that decision for those patients. And since we can't have that information readily available, then the smoking status, I think, is a good, reasonable surrogate for that.
Yeah,
Thank you.
It doesn't have to be the driver oncogene, that's the antigen. The antigen can be anything that's even a passenger mutation, you know, which smokers may have a lot of.
Okay. Thank you so much. This was a fantastic talk. We'll close out there. If anyone has any questions, you can certainly email me, but thank you so much for this fantastic talk.
That's a pleasure. And thanks to AZ for making it possible again.
Yes.
And thanks again for joining in the Ocelot study. Okay.
Our pleasure.
Thank you.
Take care.
Yeah. Bye-bye.